The press conference will start in 1 minute. May I ask the speakers to have a seat at the podium, and everyone who wishes to be part of the press conference to come close to the front? Yes. I think we're ready to get started. If everybody who wishes to be part of the press conference can join us in the front, I think we'll get started. Thank you for joining us. My name is Andrea Beziak. I'll summarize very briefly what we just heard at the plenary, and then this is the sequence that we are going to go in because certain speakers need to be giving their presentations at another session at 10:30. So we have had to change the sequence of presentations. Each speaker is going to speak for a few minutes presenting the summary of their data that they will be presenting at the conference. After the first two speakers, we'll take a few questions so that they can leave, and then we will do the other speakers in the row and then take questions at the very end. So if I can ask the speakers to be brief, because of course your main presentation for most of you will be coming up later, and do say when you're giving the presentation so that the press knows. I would just like to summarize. I hope that you are all present for the plenary session, because I think it was really a wonderful summary of the clinic, the science, the advocacy, the patients, and the survivors and the families, and all of it coming together. We are very grateful to all of our speakers and to all of the leaders in our society. But for many of us, it was very moving how it was anchored with a story of suffering and hope and life after that, and a story of living with cancer and being able to thrive despite that. So it was very inspiring, and with science and hope, the messages I had is good science is critical, hope matters, and value matters, and clinical benefit matters. And I've also heard messages that our society is actively engaged in making a difference and helping our governments, helping our colleagues throughout the world make the best decisions and invest the money where it really makes a difference to patients, and also help the less fortunate, because many of us are fortunate to work in countries where a lot of things are currently available, but so many millions of patients and their caregivers and healthcare providers are less fortunate. And I think there are progress. Of course, it's a political and a societal issue and not just a medical issue, but I definitely see evidence that our society and members of the society are at the forefront, not just aware of it, but also trying to make a difference. So that's all I would reflect on the plenary. And now I would like to welcome Dr. Vali Papadimitrakopoulou from University of Texas MD Anderson Cancer Center, who is going to summarize her abstract number 12389.
microphone is working. It's
Now
working
it is.
now.
Now it
okay.
is.
Perfect. So on behalf of my co-investigators, I am presenting the results of Empower 132, progression-free survival and safety results from this first-line atezolizumab, carboplatin, cisplatin, and pemetrexed in stage 4 non-squamous non-small cell lung cancer. Lung cancer is, of course, the leading cause of cancer death globally. We all know the numbers that are listed on the slide. The combination of immunotherapy and chemotherapy has demonstrated benefit in the first-line treatment of advanced non-small cell lung cancer. Empower 132 evaluated the efficacy and safety of atezolizumab plus chemotherapy versus chemotherapy alone in patients with advanced non-small cell lung cancer. Key points about the study design: the inclusion criteria include chemotherapy-naive patients without EGFR or ALK genetic alterations, key stratification factors, gender, smoking status, performance status, and chemotherapy regimen. The patients were randomized 1-to-1 to the two arms, which included maintenance therapy on the investigational arm with atezolizumab and pemetrexed in the control arm until disease progression or loss of clinical benefit. The co-primary endpoints assessed were investigator-assessed progression-free survival and overall survival, and a number of secondary endpoints listed on the slide, as well as exploratory analysis were included. Of note, the study allowed patients to enroll without biomarker evaluable tissue. 60% of the patients in the study had a valuable biomarker. At this analysis, the study has met its co-primary endpoint of progression-free survival investigator-assessed, with a reduction in the risk of disease worsening or death by 40%, hazard ratio of 0.6, with a highly statistically significant p-value, 5.2 months for the control arm and 7.6 months for the investigational arm for median progression-free survival. The benefit expanded across key clinical subgroups. Certain subgroups derived more benefits, such as females, Asian patients, never smokers, and patients without liver metastasis. At this interim analysis, overall survival is not fully mature. There was a numerical improvement of 4.5 months with a hazard ratio of 0.81. There were no new safety signals identified with this combination. So in conclusion, Empower 132 met its co-primary endpoint of investigator-assessed PFS in the intent-to-treat population. The addition of atezolizumab to a platinum pemetrexed backbone improved the median progression-free survival in the ITT population, 7.6 months versus 5.2 months, and a hazard ratio of 0.6, and also across key clinical subgroups. Manageable safety profile was seen without new safety signal. Overall survival data showed a numerical improvement of 4.5 months at interim analysis, and the final analysis for overall survival is anticipated in the first half of 2019. Thank you.
Thank you very much. You can have a seat. We'll hear from Dr. Robert Doble, and then we can take brief questions for both of you. And any speaker can be available later on. Becky Van would be happy to facilitate a meeting if you want to speak to the speaker in more detail. So abstract 13903, Dr. Robert Doble, University of Colorado Cancer Center.
Hi, I am pleased to present on behalf of my co-investigators the efficacy and safety of entrectinib in locally advanced or metastatic ROS1 positive non-small cell lung cancer. I'll be giving this presentation in room 105 at 10:30, so very shortly. Disclosures. ROS1 is a normal gene that when mutated becomes a cancer oncogene and drives cancer cell growth, proliferation, and metastasis. It occurs in approximately 1 to 2% of non-small cell lung cancer, so a relatively rare driver, but an important one to target. Entrectinib is an orally given, potent and selective inhibitor not only of ROS1, but other oncogenes that won't be presented today, including TRAC and ALK, and has CNS activity or activity against brain metastasis. It's a more potent ROS1 inhibitor than crizotinib in laboratory studies. It's also been shown to be a potent TRAC inhibitor that's currently in development and has already demonstrated activity in multiple tumor types. And importantly, it was designed to cross the blood-brain barrier, meaning that it can treat brain metastases and has already demonstrated clinical activity in both primary brain tumors and patients with secondary brain metastases. The results that I'll be presenting are an integrated analysis from 3 different clinical trials of ROS1 patients spread across 150 sites in 15 countries. Notably, these studies were a pivotal phase 2, Star Trek II, and 2 phase 1 studies. It consists of 53 ROS1 positive lung cancer patients who were ROS1 inhibitor naive. Notably, this patient population had 43% of patients that had brain metastasis at baseline. The primary endpoints that we'll be discussing are response rate and duration of response. The secondary endpoints are progression-free survival and overall survival, as well as intracranial or response in brain mets and the durability of those responses. We'll also discuss safety and tolerability in a much larger group of patients, all of those who received entrectinib, which consists of 355 patients across all tumor types and all gene mutations. Here are the primary endpoints. On the left-hand side is a waterfall plot demonstrating each of the patients' responses that were evaluable. You can see that the majority of patients all had tumor regression, and that the objective response rate, or those that had a major response, were 77.4% and did not significantly differ between those patients who had or did not have brain metastasis at the time of study entry. You'll also see in the bottom row that the median duration of response was prolonged at greater than 2 years, or 24.6 months. Here, there was a longer progression or duration of response in those without brain metastases compared to those with. We also evaluated progression-free survival, or time until patients came off of drug or for progression or death. And here you can see that the median progression-free survival was 19.0 months. Looking specifically at responses in brain metastases, there were 20 evaluable patients. 55% of those patients showed an objective response to entrectinib. 4 of those being complete responses, or 20%. And again, the responses in the brain were durable at 12.9 months. In conclusion, in ROS1 positive lung cancer patients treated with entrectinib, we observed clinically meaningful, deep, and durable responses with and without, in patients with and without CNS or brain metastases. Again, the response rate was nearly 80%, a median progression-free survival of 26 months in those patients without brain metastasis, and greater than a year in those with CNS metastasis. And again, it was very active in patients with brain metastases, demonstrating objective responses in greater than half, and again, these were durable at greater than a year. Although I didn't have time to discuss, this drug was very safe and manageable. Only 3.9% of patients who were on this drug had to stop due to side effects. Thank you very much.
Thank you. Thank you. We will now be able to take a few questions. If you can use the microphones, because it's a very large auditorium. If there are any questions for the 2 speakers, because they will have to leave shortly to deliver their talks and to chair sessions. If not, we'll move on, but they are available. Thank you very much. Good luck in your presentations, and thank you for your research. We will move on to hear from Dr. Lucy Kalanithi, who gave a wonderful opening to our plenary session, and also Heather Wakali, the medical oncologist who has been a key member of the team looking after her late husband, Dr. Paul Kalanithi. Welcome.
Hi, my name is Dr. Lucy Kalanithi. I'm a physician. I'm a clinical assistant professor of medicine at the Stanford School of Medicine, but I'm here as a caregiver. My late husband was diagnosed with stage 4 lung cancer in 2013. He was a neurosurgeon at Stanford, and he wrote the memoir, When Breath Becomes Air, about his transformation from physician to patient. It was on the New York Times bestseller list for over a year, has been published in over 40 languages, and was nominated for the Pulitzer Prize last year. I talked in the plenary session, which was called Patients First, about the importance of meaning and purpose, including as an amulet during times of unavoidable suffering. And I quoted Dr. Viktor Frankl, the author of Man's Search for Meaning, and Nietzsche saying, "He who has a why to live for can bear almost any how." I'm going to tweet a transcript of my talk. My Twitter handle is @RocketGirlMD, so anybody who wants to reference it will be able to find it. And then I think it's important to say, also in addition, just sort of some general lung cancer facts, which you may all know, but lung cancer is responsible for more deaths than prostate, colon, and breast cancer combined. Anybody can get lung cancer, including my late husband, who was a young, healthy non-smoker. Roughly 2/3 of lung cancer patients are never smokers or have previously quit. And at the same time, as a physician and caregiver, I think it's important to say that whether or not they smoked, nobody deserves lung cancer. The smoking stigma leads to lung cancer being underfunded compared to other cancers. But nonetheless, science is rapidly advancing, and even advanced lung cancer is becoming, or on its way to becoming, a manageable disease with some patients living for years after diagnosis. Thanks so much for having me today. And this is Dr. Heather Wakely, who was the treating oncologist for Paul and who's a professor at the Stanford School of Medicine.
So it's an honor to stand up here with Lucy. So as Lucy mentioned, so I am a medical oncologist at Stanford. I was Emma in When Breath Becomes Air. I'm also on the board of directors of IASLC and on the communications committee, and so was really honored that Lucy agreed to come and speak in our plenary because by echoing Paul's words and in her own words, which were really fabulous today, they raise the awareness of what it means to be a cancer survivor, to be living with cancer, and to be raising awareness of lung cancer. One of the universal messages that came out from When Breath Becomes Air was really Paul's ability to look at what does it mean to be living when I'm facing mortality. Lucy touched on that some today and on really finding that meaning. But I think that as we all strive to find better treatment options for our patients, we also need to always be mindful of how are we helping them live as we're trying to help them live longer and help them live better. How are we also helping them all address that question of what does it mean to that individual to be living, and how do we help them achieve their goals in the time that they might have, obviously while working towards more time, but knowing the limitations of where we still are. And I think that by having Paul's book resonate with so many people, he was able to bring others who don't have that awareness of lung cancer into those interactions with oncologists and into the interactions within his mind of what it meant to be going through that. And so I think he was able to really raise awareness of lung cancer to a much broader audience. And Lucy, with her amazing advocacy work, is continuing to raise that message. So really wonderful to have you here.
Thank you. We will move to the next presentation. Sorry? Sorry, before I introduce Dr. Evans, I'll pause if there are any questions for Dr. Kalanithi or Dr. Wakali, because Dr. Kalanithi does have to leave shortly. So if there are any, somebody's coming to the audience, just give us a minute, Bill, if you don't mind.
Sorry, just a quick clarification. Did I hear you say that roughly 2/3 of patients who have lung cancer, diagnosed with lung cancer, have never smoked or they've stopped smoking? Did I hear that right? And lung cancer kills more patients than breast cancer, prostate cancer, and what was the third one again?
Colon cancer combined. Yeah. And those are I think in terms of the non-smokers and ex-smokers, those are the North American or US statistics. In some countries of the world where there are a lot of current smokers, the proportion is different, I think. Yeah, but a lot of people, are ex-smokers. Probably the proportion is ex-smokers followed by non-smokers.
Yeah, I don't know if this was on, but in the opening yesterday, last night, there was a beautiful presentation about the importance, if you quit smoking, how much benefit there is from that. And so really focusing on the fact that for active smokers, there's about a decade of life lost, some of it to lung cancer and also to other causes. But if you quit, depending on the time of quitting, you can gain back that potential life. And so it was a really wonderful presentation last night.
And I think it's very important to the book, your husband's book, raised awareness that this can happen to healthy, vibrant people who do everything well, because, so far people ask a question, do you smoke if you're diagnosed with lung cancer? And it's not recognized that it can happen to everyone, although the risk in smokers is much, much higher. Thank you. Thank you very much. So thank you, Dr. Bill Evans, for your patience. Dr. Evans from Cancer Care Ontario here in Toronto is going to summarize abstract number 13032.
Thank you very much. It's a pleasure and an honor, in fact, to speak on behalf of my colleagues at Cancer Care Ontario. Just before I do, I do want to make a plug for the book, When Breath Becomes Air. I was very moved by reading it. I think if there are members of the audience who have not read it, you should, particularly if you're practicing oncologist. It truly puts you in the hands of the individuals who are experiencing the journey of cancer and the therapies we offer. And as also has been said, it's extremely important to try and avoid this disease, and one of the ways you can avoid it is in fact by stopping smoking. And so the focus of my talk is on the acceptance of smoking cessation services in the context of a lung cancer screening pilot which we're undertaking through Cancer Care Ontario. We began this pilot in June of 2017 at 3 pilot sites in the province of Ontario. Those of you who don't know the geography of our province won't make any sense of the map I have on the screen. Nonetheless, there are 14 health regions, and we selected 3 different regions on the basis of their abilities to deliver on a screening program, their ability to have a surgical oncology a program focused on thoracic malignancies, and a lung diagnostic assessment program, and importantly, that they would be able to have on-site, in-hospital smoking cessation services. So these pilots are being undertaken to assess how we can design and better implement a province-wide smoking cessation and low-dose CT screening program. Participants are recruited through their primary care providers predominantly, but also there's public-facing messaging. The screening navigator assesses individuals when they've been identified using the Tamaji risk assessment model, which predicts individuals who will have a greater than 2% risk of developing lung cancer over a 6-year period. And those are the candidates for the low-dose CT screening program. But we have embedded smoking cessation into the screening pathway because we believe that going into the program is a teachable moment for smoking cessation, that current smokers who participate in lung screening may be more motivated to quit than the general population of smokers, And a referral to the smoking cessation services is offered as a result to all current smokers who interact with the pilot. So they may interact in a variety of ways. They may be eligible for screening and accept the screening, and they are automatically scheduled for a smoking cessation counseling session of a minimum of 10 minutes. It can be longer and probably should be. It's with a trained counselor, and it occurs during the baseline low-dose CT screening appointment. We use an opt-out model. That is, people are automatically referred, and the navigator will have a script, something like what you see at the bottom of the screen. Your appointment for your screening session will include a session with a quit smoking counselor who will work with you to create a personalized plan that will help you quit or cut down your smoking. And that 10 or 15 minutes will involve behavioral counseling. There may be a recommendation or prescription for pharmacotherapy, like nicotine replacement therapy, and there will be arrangements for subsequent follow-up in a proactive way. Now, there are also individuals who are eligible for screening who will decline taking the smoking cessation service. We will still have them participate in the low-dose CT screening program. We will also have eligible people who decline the screening after they understand it better. If they're a current smoker, we offer them hospital-based counseling nonetheless, or direct them to one of the telephone counseling services in our province. And there are individuals who are referred to the program, but on assessment are ineligible for screening, and they, if a current smoker, are offered a direct referral to a telephone counseling service. And these are our early results, and they're very encouraging. With over 40 or 4,000 people referred to the pilot, about 80% of them, or slightly more, have been referred by a primary care provider. And this, in fact, may be part of the success of acceptance of the smoking cessation program. They may have been preconditioned by their primary care provider. We've done over 3,500 risk assessments, and 67% of those individuals were proved to be eligible for screening, and of those, 67% were current smokers. And the remarkable thing is 92% of the eligible current smokers have accepted an in-hospital smoking cessation referral. So we look across all the individuals who come to the program, whether they were eligible or ineligible for low-dose CT screening, 85% of them have accepted a referral to the smoking cessation service. And 92% of the screen-eligible people have accepted a referral, and 85% overall who are eligible have actually attended the hospital-based cessation counseling. And the difference between those two numbers may just be a timing issue. There's not everyone who has accepted the referral and been lined up for the baseline low-dose CT screen is necessarily actually gone for their first screen. And importantly, 91% of the people who have gone through the program have been surveyed and have been satisfied with the smoking cessation counseling they've received. So we are very pleased with these initial results. What will be the real important outcome of the study will be to see what the actual smoking cessation rates are. And if you come to the talk this afternoon in room 205 BD, we'll give you more results of the metrics we're using to follow the smoking cessation successes that we will expect to have with our program. Thank you very much for your attention.
Thank you. Thank you. We will move on to Dr. Kathy Albane, and then we will take questions for the last three presenters. We do have to end by 10:30 at the latest. Dr. Kathy Albane, professor from Loyola University Chicago Strick School of Medicine and Cardinal Bernardin Cancer Center, will be presenting abstract 14526.
Thank you very much. It's an honor to briefly summarize our study, Southwest Oncology Group Trial 0424, which is a case series study in ever and never smoking females and males with non-small cell lung cancer. There have been many retrospective reports of sex differences in non-small cell lung cancer and interactions with smoking status, including inherited susceptibility and carcinogen metabolism, environmental exposures, tumor stage, histology and biology, sex hormone influences, and survival. This prospective study was designed to address these factors in 4 cohorts of female and male ever and never smokers. And this is the first report of mature overall survival, including modeling of survival with multiple significant parameters that also influence survival apart from smoking and gender. 980 patients who were untreated at the time of their first diagnosis with stages 1, 2, and 3 non-small cell lung cancer were assigned to one of the 4 cohorts as shown here. The study had to remain open longer and adjust the sample size in order to get enough female never smokers to do all the various interactions with all of these data and tumor tissue parameters that were collected. The trial closed, not ever able to accrue male never smokers, despite a mass marketing effect and advocacy to gather as many of them as we could from around the country. All of these factors were assessed at baseline, and tumor tissue was collected and analyzed, in particular for mutations and estrogen receptor alpha and beta expression in the tumors. Patients were followed at least 5 years or death, and the median follow-up was 5.2 years. These are some of the statistically significant differences noted across the 4 groups. There were higher rates of adenocarcinoma in never smokers versus ever smokers. The adenocarcinoma rates in never smokers were similar by sex, but there were more female than male ever smokers with adenocarcinoma. Women were diagnosed at lower stage. Both sexes of never smokers had more Asians. Female never smokers had more cyclical hormonal exposure and less use of birth control pills and hormone replacement therapy. And these various factors were also significantly more frequent in never smokers. In addition, we looked at environmental tobacco smoke exposure, which was very high, over 90% in never smokers of both sexes. The rate of completion of planned therapy by stage was similar across the 4 groups. Estrogen receptor expression was lower in females and higher in ever smokers. And tumor mutations differed by sex and smoking status. And this is the example for the mutations in EGFR and KRAS in never smokers on the top and ever smokers here on the bottom. And you can see the marked increase in EGFR mutations in female never smokers' tumors, also in the male never smokers, and more KRAS mutations in the smokers of both sexes. This shows the overall survival out to 8 years, adjusted for other significant factors influencing survival from one of our overall model. We adjusted for age, stage, tumor type, such as histology, body mass index, and height. So female never smokers at 8 years, 64% overall survival. Contrast this to male ever smokers, 39%, 8-year survival. This shows the adjusted survivals again, but this time by stage 1, 2, and 3. And again, you see the marked statistically significant difference after adjusting for all other factors in each stage group. In one of our final models that we did, we added to these all clinical variables that influence survival the mutation status and the estrogen receptor expression data. And these are the significant parameters in that model for better overall survival and worse overall survival. And all these were independently significant. So female sex remained after adjusting for all of these other factors. EGFR mutation was favorable. P53 mutation was not. And high expression of estrogen receptor alpha in the cytoplasm of the tumor cells was also independently significant for worse survival. So in conclusion, overall survival in stages 1 to 3 non-small cell lung cancer was significantly impacted by interactions among sex, smoking status, histology, mutations, and environmental and hormonal exposures. Females had markedly better survival, not explained by treatment differences. sex hormone influences, in particular association of estrogen receptor expression with survival in both sexes, were independently significant. Despite multiple adjustments, favorable survival for females could not be explained away by any analysis or model. Thus, we believe randomized trials going forward should always stratify by sex, and that validation analyses should be conducted in targeted and immunotherapy trials in the current generation of exciting clinical trials. Thank you.
Those are really impressive differences in the curves. Very, very impressive. Last but definitely not least, Dr. Renelle Myers, who is an interventional respirologist and a clinical associate professor at University of British Columbia and based at the British Columbia Cancer Research Center, is going to summarize abstract 14485.
Well, thanks for sticking it out, and I'm pleased to be here to give you a brief look at our study that looked at the association between outdoor air pollution and lung cancer in female never smokers. The abstract will be presented in completeness at 4:20 today in room 205. Air pollution has become an important risk factor for lung cancer. The global prevalence of tobacco smoking is decreasing overall. We still have a lot of work to do there, but it is overall decreasing. Air pollution, however, is increasing, and outdoor and indoor air pollution accounts for 23% of lung cancer deaths around the world. In 2013, the International Agency for Research in Cancer and the World Health Organization listed PM2.5, or particulate matter for outdoor air pollution, as a cancer-causing agent or a carcinogen. We wanted to look at air pollution as an individual risk factor for lung cancer. We approached all new lung cancer patients presenting to our cancer agency in the Greater Vancouver area. So these were all patients that had biopsy-proven lung cancer presenting either to a thoracic surgery clinic or to the cancer agency. We asked them to then perform a detailed residential history or questionnaire looking at their entire environmental exposure, where they've lived from birth till their current address, if they've lived there for over a year. We then input those coordinates into a geographic information system, which allowed us to extract pollution surface data and compute their overall pollution exposure for their lifetime, actually till 1996, where we know that data is the most accurate. So we're probably underestimating their actual exposure history. We got this data from combined satellite and ground measurements, which has been shown to be very accurate. There was a total of 681 lung cancer patients that we got complete information on. 35% of those were never smokers. 65% were ever smokers, meaning they had a smoking history or were current smokers. I'm going to show you just a little bit of our data. We found a significant association between lung cancer exposure in never smoking females with air pollution. This is just a slide looking at only female lung cancer patients because the association was not there in males. And when we took these female lung cancer patients and plotted their air pollution exposure, which is on the y-axis, you can see a significant difference between the air pollution exposure in the never smokers versus the ever smokers. The main finding of our studies demonstrated that in women lung cancer patients, there was significantly elevated air pollution exposure in never smokers compared to ever smokers. This was not observed in males. Asians were also more likely to have a never smoking lung cancer compared to an ever smoking lung cancer. And I have a lot more data to show you, but you'll have to come to the 420 talk.
Thank you. We can take a couple of minutes if anybody has questions for our two presenters. We moved you closer to us with your name. Yes, as we're shrinking our numbers since the other session is starting in just a few minutes. But I see somebody coming to the microphone.
Pam Harrison-Medscape. For Dr. Myers, I mean, I'm from Vancouver, and it used to be a really pristine place to live. Air pollution was not really an issue for many years. Do these results surprise you at all? Because you would expect at a pristine city like Vancouver that, air pollution would not count very much, or if at all, to the contribution of lung cancer, at least in non-smoke or never smoking women. And could you maybe comment on the gender disparity between the effect of air pollution and not having any effect in men as opposed to women?
So the majority of the...
Can a microphone be put on, the third microphone on the...
Is that on now?
Fourth. Is it on? I don't think we control it. They control it.
Okay. Is it on? Thanks. So to answer your first question, in Vancouver, we do have some pretty clean, fresh ocean air. However, the majority of the lung cancer patients that presented to our cancer agency were foreign-born. 65% were female, so a lot more female, and I think we don't know the answers to that, and I think that was in the abstract prior, looking at the gender differences between males and females. There's obviously some genetic differences there, whether that's hormone receptors or pure genetics. And I think that the air pollution exposure occurred prior to coming to Canada and was probably greatly underestimated because we only have accurate satellite data dating back to 1996. Does that? The gender disparity, again, we're seeing it that female Asian never smokers are more susceptible to getting lung cancer. And we don't have causality because we only studied lung cancer patients, but this gives us a lot of information to go further and look at the general population to see if we can get some causality. And then our plan would be to create a risk prediction model so that we could screen never smokers that are high risk, because currently they're not screened, only smokers who are high risk.
Just as a follow-up question, so that was sort of my next question, so what can you do about it? I mean, you got to live somewhere, and even in Vancouver with almost no pollution. You're going to use this information to predict or identify patients who are perhaps at elevated risk, and would most of the patients, the never smoking females, would they have also been Asian? So it was like a triple whammy?
Yeah, it is a double whammy actually, because the majority were Asian and predominantly never smokers, predominantly women and predominantly Asian, and those were independent risk factors. So being a woman was its own independent risk factor, being Asian was another independent risk factor, so they did have double whammy.
I'll let Dr. Albain comment and then we'll close.
So I think too,
Sorry?
we have to
Okay.
consider that there are many parameters that need to go in these models. So I would ask if environmental tobacco exposure we found throughout the lifespan played out here too. So it's not just one factor. It's not pollution. The men in our study had higher estrogen receptor expression, independently important as well. It wasn't just the women. So the more factors you can put in these models, I think we're going to get closer to the answer, but it's not going to be just one thing.
We have one question in the back of the room, and do we have time for 10:30? So we'll just take the question in the back of the room, and you can ask the presenters in private. Go ahead.
Sorry, real quick question about the pollution. Are you going to validate that in other locales, Colombia, China, those sort of areas?
We're going to start to validate it in Canada with a large population, a large general population that we have data on that gives us a denominator. Because right now we don't have a denominator, we only have actual lung cancer patients. So that'll be our first step.
Thank you.
Thank you very much. If you have other questions for the two presenters, I'm sure that they will be happy to take them. And we thank everyone for their attendance.
And if we can add air pollution to that, of course. We have data on it. We have